All right, welcome to the AOMPS Hands-On, Hands-Off podcast. I am Dr. Nick Rainey. I'm part of the research committee. So my job is to interview researchers. And so that's why we have Dr. Bremen Abuhl and Dr. Dallas Ehrmantraut. Did I get both of those names correctly?
You got it.
Okay, very good. They have done some interesting research, at least what I find interesting. So hopefully our listeners do as well. A little bit about them. I'll give a little bit of intro, and they can fill us in. They both practice together and teach together in North Dakota. They're at University of Jamestown's DPT program, and they're both PhDs, and they're also in orthopedics. Dr. Abuhl is actually waiting for his results to see after he's completed residency, waiting for his results. Fingers crossed for his OCS. And Dr. Ehrmantraut already has his OCS as well. Dr. Abuhl, is there anything that you would like to add to that background, particularly in light of what has made you interested in first contact physical therapy?
Yeah, it's a really good question. I think it came about throughout DPT school. So I actually went here where I teach to the University of Jamestown, and the program is set up to try to push the profession forward. So there's always conversations about how can we practice at the top of our license and how can we provide the best patient care. So as I went through school, there were developing conversations just among faculty and I started my PhD halfway through my DPT. So it was kind of this converging of what I'm learning in class and then trying to expand upon that and study some of the questions I had about kind of PTs acting as primary assessors, first contact role. So that's kind of where the interest came about, was probably from, conversations with faculty and collaborations with some of them. And then as I went into developing my PhD research questions, it kind of flowed directly into that. And thankfully, at the same time, Dallas and I were, he was my professor at the time, but we were working closely in class, of course, and then in the clinic, in the pro bono clinic. So we kind of started having some interesting conversations there.
Wow, that's a very interesting background, starting the PhD while you're still working on your DPT and then going on into residency, and that's a lot all at once. I don't need to tell you that. You realize that.
Throw a kid in the middle.
Dr. Ehrmantraut.
I was going to say throw a kid in the middle of it too for Bremen.
Oh, good. We didn't want to make it any easier.
Yeah, exactly.
Dr. Ehrmantraut, what is your background that I didn't share, particularly what makes you interested in first contact physical therapy?
Yeah, it's obviously an area of both practice and research that Bremen and I and yourself are interested in. And honestly, it kind of started during my residency. It was an orthopedic residency in a large health system in Fargo, North Dakota. And during that residency, you had various opportunities to shadow different disciplines. And one of the places that I shadowed was just in a family practice. And throughout the morning, we're seeing things that are definitely not within my scope of practice. But then one of the patients that was upcoming was coming in with, I believe it was shoulder pain. And I was excited to see how this NP would practice in that situation. But she, on the other hand, had a different perspective. She looked at me and she said, "Oh no, now you're going to realize that I don't know what I'm doing with musculoskeletal pain." And so that is what really sparked my interest in this. And she was humble enough to recognize, like, I'm not as interested in musculoskeletal stuff. That's not where I've put my dedicated efforts towards learning. And I'm not an expert anymore. I would rather do these other things. So that's what got me interested in thinking about what should our role be in these health systems? What should our role be in private practice? What should physical therapist role be? And then that's when I started doing some literature review, doing additional observational experiences. Early on in my research inquiry during the PhD, I shadowed an orthopedic PA and I asked him, when did you get all this training to do all of these injections and surgical assistance? And the response was, Dallas, it was literally all on the job training, which sparked a lot of interest for me, but also a lot of fear in me as far as the patient care that is being provided right now. And it's not to say that that's their fault by any means. It's just the system that's been developed. And I think the main thing that I took away from it is DPT education is really impressive when it comes to preparing clinicians to care for musculoskeletal conditions. And if that's the case, and these other disciplines don't have as rigorous education in those areas, then how can we manipulate or change the system, the structure that's in place to improve patient care, improve patient outcomes, improve the efficiency of healthcare systems, and honestly offload the overburdened providers that are caring for these patients already. So I think that's a brief summary of what sparked my interest.
I like stories like that. Thank you.
Mm-hmm.
That's a great lead in to the paper that they authored. This came out in 2025 in Physical Therapy Journal. It is titled "First Contact Physical Therapy Compared to Usual Primary Care for Musculoskeletal Disorders: A Systematic Review and Meta-Analysis of RCTs." Would one of you mind giving us like elevator style, summary pitch of a high level of what this article was about, and then we can dive into some more questions.
Yeah, for sure. So as Dallas mentioned, he and I both became really interested in what type of provider manages patients with musculoskeletal conditions, and what kind of provider is best suited for that role. And so throughout literature review and personal experiences, we recognize just how overburdened the healthcare system is in general. And when you look at some of the numbers, it varies by country, but musculoskeletal disorders are one of the primary reasons for years lived with disability and for pain and healthcare spending. And so we were really interested in how can we improve the value of care and the type of care for patients with musculoskeletal disorders, while also supporting our healthcare systems and teams and offloading providers to allow them the capacity to better manage other conditions like Dallas mentioned that maybe they're more interested in or more prepared to do so. And so by investigating that, we wanted to look at how do outcomes for patients, including clinical outcomes, so things like pain and disability and health-related quality of life, and also the societal side of things, so healthcare utilization like clinical imaging or prescription medications and the cost to the patients, how do those differ when a patient is first evaluated by a physical therapist in the first contact role versus a usual care provider, which, physician, nurse practitioner, or physician assistant. So at a baseline, we wanted to assess the differences. Now, this has been done before, that multiple systematic reviews have looked at the same thing. None of the studies had looked at just randomized controlled trials, and then some of our outcomes hadn't been studied either. So healthcare utilization hadn't been studied with a meta-analysis, and neither had health-related quality of life. So we wanted to get a good broad picture of when we're in these roles, what are the patient outcomes? Is there a difference between this usual primary care and the first contact physical therapist? So when we dive into some of the methods and results a little bit later, we can talk about those specifically. But ultimately, we wanted to know, at baseline, are we at least as good as what we're already doing in the medical system in managing patients with musculoskeletal disorders? Because that should be the minimum, right? At minimum, can we do this as effectively and achieve the same patient outcomes? Not necessarily having to prove something. We just wanted to know how we compare. So the findings were interesting. In one of the two of the outcomes that hadn't been studied before with a meta-analysis, clinical imaging and prescription medications, we found significant less healthcare utilization with the physical therapists as the first contact provider compared to usual primary care. And then all of the outcomes were statistically similar to usual primary care compared to physical therapy.
That's a great overview. Thank you. I want to back up a little bit with terminology. As when I was a student long ago, we talked about direct access and how many states have direct access. Some of the literature now is showing first contact physical therapy. I know in Utah, they recently passed a bill that classifies physical therapists as primary care providers, and other states have been pushing for that as well. Is there a difference between the terms? Why would you choose first contact physical therapy versus direct access or primary care physical therapy?
We went back and forth on this a lot, actually, and part of it was just due to the literature review and in seeing the variability. But if you look at definitions of primary care or first contact, you'll see variability throughout the research. I mean, it all started with direct access, right? We want our patients to be able to choose to go see a physical therapist without having to have a physician referral. So that's kind of where it started, back with like Vision 2020, and even before that, trying to get direct access for patients to physical therapy services. Then as we continue to look at integration of PTs into healthcare systems, I think there's multiple different ways that PTs have been and can be implemented. And so we went back and forth on the primary care versus first contact definition. But the first contact definition is primarily, you're the first provider that this person sees for their plan of care. So that could be in a primary care clinic, or it could be in an orthopedic walk-in, or in a sports environment, or in the emergency department, or there's a vast range that it could be. Versus when you think of primary care, that's typically, at least in the healthcare system that we work in, we talk about family medicine and internal medicine as kind of that primary care. But I think that physical therapists have been integrated and can be integrated in a wider range than that, rather than just that overarching, overarching big scope. You can manage a lot of different conditions, whereas we're focusing on musculoskeletal disorders rather than vestibular and oncology and pelvic floor and whatever else it is. So we wanted to focus primarily on the musculoskeletal disorders. So that's why we chose the first contact term. Anything to add to that, Dallas?
Not necessarily. I guess just to reiterate, the primary care definition was recently released for physical therapy, and it's very comprehensive and went through multiple iterations, and it does a great job describing what primary care physical therapy is. And we felt in our study, because we're isolating musculoskeletal conditions, that it wouldn't do the primary care definition justice necessarily. And so that's why we went with the first contact provider. Is we're focused on musculoskeletal disorders, and like Bremen said, we want to make sure that we're isolating studies that had physical therapists as that first point of contact before they saw anybody else.
That was a fabulous answer. I figured that when you've spent a lot of time here, you know the nuanced differences of words, and so I figured you'd have a great, insightful answer. So I appreciate that. Let's go on to some of the studies that you were looking at in there. As both of your experience have been in American, healthcare in the United States. Looking at the studies, if I remember right, there's only one that was based. One of the RCTs was based in the U.S. 5 were in Sweden, and the rest were scattered. Tell me a little bit about how does that affect the results? What was interesting to you based on geography?
Yeah, we weren't totally sure what we were going to get as we began our literature review and trying to go figure out our search terms and determine which studies we're going to include. But we knew that we wanted to go global because we weren't sure if there had been enough done in the United States as far as randomized control trials that would be able to suffice for a meta-analysis. And lo and behold, we were right. As you said, there was only one RCT that we included from the United States, 5 from Sweden, and then a scattered mix from there. So yeah, half of our articles were from Sweden. And from there, I think it kind of just shows that this has been studied outside of the United States more than it has within the United States from a randomized control trial perspective. And because of that, there are limitations as far as the direct applicability within the United States. However, what I will say is this idea of primary care, first contact physical therapy is not new to the United States. Right, the United States military has had first contact physical therapists practicing in those roles for over 50 years. When you look at the civilian sector, Kaiser Permanente has been having physical therapists in primary care first contact roles for about 30 years now. when we began our literature review, we came across an APTA perspective that did a great job breaking down country by country and what physical therapists are practicing, how they're practicing, what their privileges are as far as scope of practice is concerned in these different countries. And another thing that stood out to us that we took from Aaron Kyle's study a little while ago was at that time, the United States was the only entry-level doctorate degree when you look at it across the globe as far as physiotherapy training. Everywhere else was either bachelor or master's, but yet they had more expansive scopes of practice than we did in the United States, which is something that we thought was interesting, and it led to better discussion as far as what we're doing here in the United States and what other countries are doing as far as their advanced physiotherapy practice or standard physiotherapy practice, to note the differences, learn from the differences, and try to apply those and make sure we're closing the gap as far as the quality of care being provided in the United States.
I'm glad you opened it up to the more than just the United States when you're setting, forth what you want to do, because obviously, like you said, only one showed up in the United States, even though it's been done. This, like you said, it's not a brand new concept.
Mm-hmm.
Let's move towards imaging. One of your findings related to imaging, and that's where there's been a pretty big movement throughout the United States for physical therapists to have increased imaging privileges. First, what was the finding in your paper, and any other thoughts you have on physical therapists ordering imaging?
Yeah, it's one of our key interest areas and something that we hope to continue studying outside of the scope of this paper. But the main finding from our study was significantly less imaging utilization from the physical therapy group. And so when we look at just overall healthcare utilization in the United States, at least, is we see a lot of unnecessary images being ordered. We see that in our own personal practice, but also in some of the research that we read in our literature review is we're seeing this expansive overutilization, or we might change the term to kind of a misutilization, where we're relying on it too heavily to influence our clinical decision making. And when we look at the findings, we see significantly less healthcare utilization in general, less imaging being ordered. We don't necessarily need to show that we're using less imaging, but rather we would hope in the future to be able to identify that we're more appropriately using imaging for patients with musculoskeletal disorders. When you look at the some of the research on when we should use imaging for musculoskeletal disorders, a lot of the conversation is if it's going to change your management plan. And so I think that's one of the key features of ordering imaging, is if it's going to change your management or not. And if it's not, then you might rethink your utilization of it. So the imaging conversation is a really comprehensive and challenging one to have, because I think it challenges a lot of biases with imaging findings in asymptomatic control groups, and the safety conversation plays into it too. Of well, are you just ordering an image to protect yourself in the event that something does happen, or are you actually using clinical reasoning and decision making to come to that decision of ordering an image? So certainly as the scope of practice expands, we are interested to continue studying it to see, as PTs gain access to this, are we going to go the other way on the pendulum, where now because we have the access, we're just ordering it as much as any provider is? Or do we at a baseline have more tools in the toolbox to make those decisions than just using an image to guide the plan of care?
So it sounds like the finding in the study was that it's ordered less when physical therapists are first contact providers. What the hope is, it didn't elucidate this in the study, is that decreased ordering is appropriately decreased ordering. Obviously, we know that there's a lot of excessive ordering, but what we may not know is, are we underutilizing imaging? And if more privileges we get, are we going to overutilize it like maybe other professionals have?
Exactly.
Any other thoughts on that, Dr. Ehrmantraut?
No, not necessarily. I think Bremen did a good job summarizing the results. 45% less imaging being utilized in our study, and Yeah, it's the misutilization that we're concerned about. We don't want to underutilize it. We don't want to overutilize it. It seems as though the consensus in the literature right now is that it's overutilized. The only metric that we've seen in our literature review as far as are we utilizing it appropriately are there adverse events in the cases where an image wasn't referred for? And we haven't seen that in any of the literature. So that's a win, but also, as Bremen talked about, it may end up changing your plan of care if you get an image in some circumstances. And so we haven't picked up any additional information on those things.
Cool. Thank you.
Mm-hmm.
Let's move on to medications now. There's also findings with relation to how much medication patients were using when physical therapists were first contact providers. What were the findings, and what implications do you think that has for practice?
Yeah, similar to imaging, for medications, the utilization was 71% less. So for imaging, it was 45% less in the PT group. For imaging, it was 71% less in the PT group, which is a significant difference between groups. I would think that's a win, especially since we're seeing patients are getting similar, if not superior outcomes. And so, of course, we would want that. If you don't have to be taking a medication, well, let's not take that medication as long as your health won't have negatively impacted. The one thing that I will say with the medication part is it did have considerable heterogeneity, and it was based on low certainty of evidence. So we have to take that with a grain of salt to some degree. The language that we would use for prescription medication in our study is that it may reduce the utilization of prescription medication. There was only one study that explicitly listed the types of meds that the PTs were able to prescribe. And in that, it ranged everything from a simple NSAID, ibuprofen, all the way up to opioids, which we were kind of surprised by, considering most of the time, from our research at least, in these countries or in different military settings, if PTs do have a scope of practice that allows for prescriptive authority, it's usually somewhat limited in what they can prescribe. So I thought that was pretty interesting too. As far as the practical implications of this, I think it's quite timely. Over the last few years, there was an APTA task force that was developed to look at feasibility of prescribing medications and ordering lab testing in the United States. And they put together a really well-written document that describes the feasibility of that. And then within the last year, the APTA put out position statements talking about how prescriptive authority is something that they stand by. And so I wouldn't be surprised if over the years, similar to imaging right now, where we're seeing more and more states giving imaging privileges to physical therapists, we see the same thing with some level of prescriptive authority.
Very timely. That's why it's in PTJ. So thank you. Yeah. You mentioned a little bit about clinical outcomes and that they seem to be at least as good. Can you also expound on what were the findings in the paper and what your opinions on those findings are?
Yeah, so when we look at the clinical outcomes, so pain, disability, and health-related quality of life, there weren't any statistically significant differences between the first contact physical therapy group and the usual primary care group. That gets back to kind of that conversation of we want to see if we're at least as good as the standard of care in improving pain and disability, and then improving health-related quality of life. I think with a study, with a statistical analysis like a meta-analysis, you can get broad changes in pain or disability. You definitely can't capture the nuance of clinical scenarios. And as we continue to learn about the complexity of pain, I don't think it's too surprising to me that there wasn't a massive difference either way. But when you look at the two groups, we did see improvements in both groups. So from baseline, the physical therapy group had improvements in pain and disability and health-related quality of life, and so did the usual primary care group. So I think that's another just sign that this is a feasible integration of first contact physical therapy into healthcare managing patients with musculoskeletal disorders. Clearly, it's not as nuanced as specific, maybe patient-specific findings as far as returning to meaningful activities for the patient, or an improvement in ways to manage their pain in the future. It doesn't capture the complexities of that, so future studies would have to investigate that. So yeah.
In summary, it sounds like the main findings that we have pretty similar outcomes with less imaging and less medication. Mm-hmm. Is there anything you want to add to those results of that summary of results?
I think one of the limitations of studying clinical imaging and prescription medications in PTs is the scope of practice definitely limits the interpretation of that, where in all the studies, PTs were able to either directly order imaging and prescription medications, or indirectly, where they were given a pathway where if they determined that an image was appropriate, but they didn't have the scope of practice in their area to physically order it, they could indirectly order it by communicating with another provider to get that image or that prescription medication, which inherently will probably limit the utilization of it, which needs to be understood in the interpretation of the results. Additionally, in a couple of the papers, there wasn't data on which provider ordered the image or the prescription medication. So we looked at downstream results. 3 months or 6 months out from the intervention, did this person receive imaging at all? And we don't necessarily know if the PT initiated that or if the patient went elsewhere for it. But I think that it still demonstrates that there was less imaging and prescription medications utilized, whether the provider ordered it on day one or if it came, in the months preceding.
As you talked about the time frame there, it looked like you obviously know all the numbers in there better than I do, that a lot of the outcomes were looking at about 3 months. I'm very curious. I think physical therapists have had really an opportunity to decrease downstream costs even further, the 12 and even 24-month mark. Is the 3 months accurate? Am I remembering that correctly? And if so, what do you think would happen if we had studies looking at the 12 and 24-month marks?
Yeah, you are remembering it correctly. We focused on kind of the medium term 3-month time frame as far as our meta-analyses are concerned. And the reason that we didn't do longer duration is because we just don't have enough randomized control trials out there to be able to run a meta-analysis that would give us enough valuable insights to make any claims. So yeah, definitely another thing that we're interested in continuing to investigate, because there's a desperate need for it right now. As far as speculating on what we might see, I would like to think that the PT groups would continue to see less utilization, appropriate utilization, and at the same time, similar, if not superior, clinical outcomes as well. It's hard for me to say for sure. I think one thing we might run into as far as issues with a long-term randomized control trial like that is crossover between groups. If you see a physical therapist for the initial session and then 3 months go by, the patient maybe isn't seeing enough improvement, now all of a sudden they want to cross over to the usual primary care provider because they didn't get the image they wanted with the physical therapist. Something along those lines. So that's one data point that I'd be interested to check in on, is what is that crossover rate and how does that impact the results? But then the other thing is, I think if we look at musculoskeletal health in general and the short-term versus medium-term versus long-term outcomes, the improving long-term outcomes comparing methods or provider types or specific interventions seems to be a bit more challenging than the short-term ones. It seems like there's always inevitably some sort of regression to the mean. An example that comes to my mind, when I was during my residency year, there was a new orthopedic surgeon that came in, and he stopped sending his total knees over to the physical therapist because study was published and it showed no significant differences at the 2-year mark, whether they did post-op physical therapy or not. And it caused a lot of havoc in our department and the health system in general. It was news to us that was the case, but really we did put ourselves in a bad position by seeing everybody 2 times a week for 12 weeks when it maybe wasn't necessary. So I can see where he was coming from. And from a research standpoint, he was right. The study showed there were no significant differences 2 years down the road. But one of my mentors, Scott Brown, always talked about that's important information. What if we could help them get better faster? What if we could care for them appropriately early on to help them achieve better outcomes early on? And in this case, even though it's a different type of a study, I wouldn't be surprised if 2 years down the road, we end up seeing some sort of regression to the mean, because we're dealing with complex musculoskeletal conditions with complex health systems. But at the same time, the hope as a physical therapist would be to see still significant differences in imaging utilization, prescription medication utilization, and similar to superior clinical outcomes.
That is a great overview. I know a lot of your data that I've looked at is episode-based care, a lot of the times in that 90-day window.
Mm-hmm.
But same as your mentor, we've all seen that. Like, if I could get back, if I had told him and I could walk, a mile in, a month or two versus 8 months or a year,
Mm-hmm.
I'd be willing to pay a lot of money to get back, walking a lot quicker.
Yep.
As far as one thing I was interested in your article, one of the risk of biases was a deviation from intended interventions. Could you expand a little bit on that, please?
Absolutely. Yeah. So the tool that we used to assess risk of bias is the Cochrane risk of bias. It's their second version of the tool. And so there's a list of questions that they ask on a bunch of different domains. And one of the domains is deviation from intended interventions. And so some of the things that they ask in that domain is, was there blinding of the patients? Was there blinding of the carers or the providers caring for the patients? Was there crossover from the allocation groups? And so when you have different responses to those factors, such as it's impossible to blind the person who's caring for someone, whether they're providing physical therapy or whether they're providing usual primary care. There's an inherent risk of bias with this type of analysis that's impossible to avoid. In some of the studies, that was the case where it had a lower risk of bias because that's just inherent to the study design. But then in some of the studies, there was reported some evidence of crossover. So if the patient went through the allocation and decided that they wanted a evaluation from the primary care group or vice versa, that was considered a deviation from intended intervention, where they ended up receiving both usual primary care and first contact physical therapy. So in the event that there was deviation and no blinding, that would be a higher risk of bias for that domain.
Real life makes research messy, doesn't it?
It does. It
does. So let's talk more big picture. United States healthcare. All three of us are on the same page that we would love to be able to see physical therapists be first contact, providers in a number of settings and much more ubiquitous than what it is. All states have some form of direct access now. It's far from being the norm that patients are coming to see us direct access. What system-related challenges do you see for making this the norm and more prevalent, so we have more studies that we could have a United States meta-analysis? What do you see as the challenges of making this the norm?
A variety of things. Of course, with research and especially even beyond research and looking at just clinical practice in general, when we're working with complex health systems and legislation, there's going to be various factors from multiple angles that play a role in making something actually happen. From my personal experience, working in a large health system, it really started with one department who was all on the same page, getting stakeholders from different disciplines, getting managerial support, and coming together to develop this structure and implement it. Track how it goes for a little while, and then expand, and then expand, and then expand. And then all of a sudden we might have system-wide changes, and we can report that out to the rest of the state, rest of the United States, whatever it might be, to learn by example and try to implement what's already been in. And there's been study after study kind of talking about how PTs can be integrated into these different roles. When we look at United States in general, and you compare it to the other countries that we investigated and how they're seemingly more easily integrating PTs into these roles, one thing stands out pretty clearly, that the payer model drives a lot of what happens in healthcare. And so until we can make sure that these health systems are getting reimbursement from us being in these roles, and until we can make sure that there's appropriate care being provided to justify all of that, it'll be challenging to see this integrated regularly across the United States. And then you get into the different types of insurance and the different restrictions across each. There's a variety of things just in that entity by itself that makes it challenging and adds a lot of barriers. Beyond that, one other area of research in my agenda for the PhD was looking at stakeholders and their beliefs in getting PTs into these roles, and basically asking them what their opinions were of PTs compared to these other allied health professions, and getting results on that, so we can make sure that we're not just making an informed decision based on the research that we've conducted and consumed, but also what are the perspectives and beliefs of relevant stakeholders who can help move the needle in these directions.
Very insightful. Dr. Abuhl, what thoughts do you have?
It's really good. I think Dallas hit the main one of the main limitations that we keep coming across of. We've presented this research a couple of times now, and every time there's always really good discussion afterwards of opinions, both in support of and both which are have questions that need to be answered before this becomes more widespread. But across the board, it seems that patients are satisfied when a PT is the first point of contact. Providers value our opinions, and stakeholders seem to view physical therapy highly. But I think it keeps coming back to the fee-for-service model and the payer model that we have, where healthcare systems care about patient outcomes, they care about patient access, but they also care about the bottom line at the end of the day. And so in our discussions with some of the leaders in healthcare systems in this area, one of the biggest questions that they have is, well, if a physician gets reimbursed X amount of money for seeing a patient with back pain, and a physical therapist gets reimbursed a third of that or half of that or whatever the number is, how can they justify pushing for that if at face value, it seems like it will decrease revenue for the healthcare system? And so I think there's a lot of conversations to be had around that. And ultimately, I don't know if we'll know until we try it. But some of the conversations that we've had is there's no shortage of patients with back pain. There's no shortage of patients with musculoskeletal disorders. In fact, there's a surplus and there's a shortage of providers. So when it comes to patient care and safety, the patients who have those concerning disorders or things that need urgent or emergent medical care quickly are having to wait, because the patients with musculoskeletal disorders and other conditions that are lower urgency are occupying such a large proportion of the space. So one of the questions that we have, we don't have an answer to it, but one of the questions that we have is, if physical therapists can reduce that burden on usual primary care providers, take away a large chunk of the patients with musculoskeletal disorders, does that free up the providers to see patients with more complex conditions, cardiovascular disease, diabetes, cancer, all these things? And does that improve patient access, decreasing wait times, improve patient satisfaction? Does it improve attrition rates? All of these conversations can be had, and ultimately, I don't know if we'll know until we try it. But I would argue that with the amount of patients that we have and the shortage of providers, integrating physical therapists, even if it's reducing the reimbursement for that individual plan of care, overall might actually help the health system rather than hurting it. So I think that there's definitely some reform that needs to happen with the payer model. But integrating physical therapists in this role is likely to support our health teams and empower the other providers to do what they do best as well.
That's a lot of good insight there. I've always, ever since I was a student, my whole time in this profession, we see research showing the savings that physical therapists can provide. And then I've realized that savings in a fee-for-service system means that somebody's making less money, and it sounds good in research, but then you get into meetings with stakeholders, and in a fee-for-service system, less money means that somebody's making less money. And value-based, it can be different. There's ways that even in a fee-for-service that maybe then they can go treat other things, but that's conjecture. If they're wrong, there could be people that are upset in those systems.
For sure.
So part of the research you had was on triage. If you had your druthers and you could design a system, you said, we're going to embed physical therapists to provide the maximal benefit possible. What would it look like for physical therapists in primary care settings, triage, so that way patients could get the help they need the quickest from the right provider?
Direct triage model is my quick response, I would say. Seth Peterson and Katie O'Bright, they published a perspective a couple of years ago, maybe 3 years ago now, that looked at the different models within the United States as far as primary care physical therapy is concerned. And they highlighted two primary models, the warm handoff model and the direct triage model. The warm handoff model being they go in to see their, let's say it's an NP for a general inquiry. They talk about their shoulder pain. The NP calls the PT in the moment and sees if they're available. If they are available, the PT comes in and they provide an evaluation to that patient on the spot. It does a good job of making sure the PT sees them early and hopefully can recognize if PT is necessary. And if so, hopefully there isn't as much attrition from that first appointment to their follow-up PT appointment. When it comes to first contact physical therapy, though, I don't know if that's necessarily first contact physical therapy. They've already been somewhat evaluated by the other provider in that situation. So that's why Bremen and I are advocates for the direct triage model. The problem is it might have more challenges logistically to try and figure out right away and make sure everybody is on board with that as far as other personnel and other stakeholders. So the ideal model in my mind is kind of similar to that really valuable study done in the military a few years back that basically allowed for a call to action across the United States military saying we should be practicing in these first contact roles, where they had a series of questions. If they answered this to this question, they would be put in the PT group. If they answered this to this question, they'd go into the usual primary care group. And if at the end of the series of questions, they're still in the PT group, they would be directly triaged to the physical therapist. Physical therapist would be the first provider that provides care for that patient. The person doing the triage, ideally, it could just be a patient thing where they fill out a form online and then they get set up with the appointment right away. Or maybe they call in to a patient access representative and the patient access representative brings them through that. I know there's challenges to it. It sounds easy. I know it's not, but from my perspective and the patient experience perspective and patient outcome perspective, I think it would be valuable. And that's going to look different too, depending on the setting that you're in. If this health system has certain policies and procedures and this one has different policies and procedures, that triage system might look a little bit different. They might ask slightly different questions, but at the end of the day, can there be some sort of a questionnaire simple enough to have a nurse or a patient access representative or the patient itself to complete it and then directly be triaged to a first contact physical therapist? Bremen, do you have anything to add to that?
Yeah, it's definitely based on healthcare system, but also state and scope of practice too, where if you have access to ordering imaging and laboratory studies and specialty referral and all of these healthcare necessities are given access to the PT, it makes a lot of sense to do the direct triage model. But we're seeing a ton of limitations across the states still, in whether it's even still limitations in direct access. In Minnesota, after 90 days of seeing someone, you still have to get a physician referral. In multiple different states, there's limitations where they can't do certain functions like ordering imaging. So the direct triage model is something that is the ideal situation, but there's multiple steps we need to hit before getting to that point.
Yeah, the way that Bremen and I have talked about it is kind of like 4 different levels within the United States. First, what's the sector? Is it civilian or is it military? Then we have state legislation and what are the requirements there? And then it's health system to health system and what are the policies and procedures within those? And then even below that is department to department. How does each department operate within itself?
I think there's a lot of wisdom to that model. If we're hoping that we can educate every patient on where they should be going first, that's going to be a challenge. If we just have a system, everybody, gets triaged quickly, with low contact, there's a lot of benefit. Well, that's the end of my, questions that I had planned for us. What else were you hoping that you could share about first contact physical therapy that you haven't had an opportunity to share so far?
One thing that just came to mind as we're talking about triage model is when you look at a lot of the research as far as their inclusion and exclusion criteria, even in these first contact studies, some of them will specify, the patient can't have had any recent trauma, or the patient can't have any signs or symptoms of concerning pathology or anything like that. And I think that limits the applicability because we talk about not having any adverse events. But in a true first contact scenario, the PT should be tasked to identify those things and refer when necessary, demonstrating their clinical reasoning and decision making, where you can't always specify that the patient is not going to have a red flag or sign of something more concerning. So I think that we need to stop putting barriers up to what the PT can or can't evaluate. Where if I'm in a first contact setting and the patient has neck pain after a motor vehicle accident, I should be able to identify, does this person need imaging? Do I think something serious is going on? And if I do think something serious is going on, at what level of urgency am I going to refer this patient? Do they need to get an X-ray today, right now? Do they need to go to the emergency room immediately due to either cardiovascular concerns or spinal cord injury potential? Like, that's the conversation we need to be having. And if we limit that and put these barriers up to what we as a profession or what the medical system thinks we can handle as physical therapists, I think it's going to limit our interpretation of how safe PTs can be in this role.
Yeah, the
I like it. Dr. Ehrmantraut, what do you think?
Yeah, the only other thing that I would add is kind of like a call to action, to be honest. Working in the health system that we were in, it was challenging to get physical therapists to want to step into these roles out of discomfort. Like, they might be a bit of uncomfortable stepping out into these new roles, or the extra workload, or scope of practice concerns, but whatever it might be. So a call to action to physical therapists to step into these roles. Like, we have very good musculoskeletal education through our DPT education. And even before that, people claim, well, it hasn't always been a DPT. That's true, but we have had military providers for the last 50 years who have accomplished similar things. And so we should trust our education and our training, clinical experience to be able to provide this care, and recognize that we, in some cases, should be the provider of choice for musculoskeletal conditions. So one thing as a professor and seeing each new cohort leaving and the positions that they take, it does seem, to me at least in our region, that it's the younger clinicians who are motivated to maximize their DPT education and step into these roles. And I would continue to encourage them and tell them to stay motivated and continue to push forward and and try to change the healthcare system to improve the quality of care being provided to these patients who are dealing with musculoskeletal conditions, to improve the burden of current primary care providers and them being overworked and not having enough of the primary care physicians, and increase volume of patients, and try to help out the health systems by stepping in to these roles, as uncomfortable as it might be right away, to improve patient care and improve the provider burden.
Let's be real doctors.
That's right.
Thank you, Dr. Abel. Thank you, Dr. Ehrmantraut. I appreciate you being on here today and for your hard work on this research.
Thank you very much.
Thanks, Dr. Rainey.
Thanks for listening to Hands On, Hands Off, the official podcast of AOMT. Subscribe now so you never miss an episode, and connect with us at aomt.org or at AOMT on social. Opinions are those of the guests and not official AOMT policy. See you next time.